Welcome back to the Woven Well podcast. Today we have the opportunity to speak with Dr. Naomi Whittaker about the keys to preventing scarring, adhesions, and repeat endometriosis surgery. This is huge. If you're dealing with endometriosis or suspect that you are, please listen to this episode before you have any sort of surgery to remove it, if at all possible. Dr. Whittaker is a Pennsylvania based board certified OBGYN and fellowship trained surgeon who specializes in the Creighton model fertility care system and NaPro technology, which works cooperatively with a woman's body to treat the underlying cause of gynecologic issues and infertility, such as endometriosis, PCOS, etc. She's the founder of Restorative Reproductive Medicine Academy and has dedicated her practice to women's restorative reproductive medicine, compassionate healthcare, and education. And we are thrilled to have her back on the show today. Dr. Whittaker, welcome.
I'm excited to be back. Thanks for having me.
Yes, last time we talked about ovarian cysts, which is something that a lot of women deal with. They don't think there's any help or solution for them. This time we're talking about endometriosis. And in both scenarios, there are things that we can do. It's just not always talked about. So, would you like to introduce yourself a little bit more and share why you know so much about endometriosis?
Sure. Endometriosis period is something that's probably a lot more common than we even realize. I dealt with it for myself personally for 20 plus years, I think, almost 20 years, sorry, actually. And I didn't realize I had it even when I was an OBGYN and OBGYN training. I went through that, had no idea, even though I had pretty significant symptoms. And then in fellowship, dealing with endometriosis patients, that was one of the main things we dealt with in women who traveled to us for surgery. Most of these women had infertility. Some also had pain. I identified my own symptoms in these patients over and over again. And that's when I finally figured out my diagnosis. But just to show you how hard it is to even figure it out when you're in doing this every day. That's why I bring that up. So it's a super common condition. Unfortunately, it's misunderstood, and a lot of women just think that pain is normal, or a lot of these symptoms are normal or in their head, or whatever kind of justification we have. We're told by somebody, a mother or a doctor. Most people just kind of say, well, just put up with X, Y, or Z symptom. And it's also an elusive diagnosis because you need really surgery to diagnose it. Imaging sometimes can detect it, but usually only when it's more advanced. And so you really have to have a very high suspicion to be able to find it.
Yes. And so you have dedicated so much of your work to helping women know or suspect if they have endometriosis and get the solutions that they need. And everyone's going to medical professionals who may be local to them, or maybe they are traveling, like you referred to. But we always want to make sure that every patient gets the best care possible, because that's what every woman deserves, is that kind of dignified care and compassionate care. So obviously not everyone can work with you or just one particular surgeon. That's okay. But there are ways that we can go about educating ourselves and advocating for ourselves to get the best care possible. And that's included with endometriosis surgery. So one of the things that we hear a lot about is scarring and adhesions. Why is scarring, why are adhesions so common with endometriosis patients?
Sure. So when I talk about endometriosis at a surgical consult, I always talk about adhesions because they go together. So the more advanced endometriosis is, especially with endometriomas that can rupture and cause bleeding, the more likely someone is to have scar tissue. So just the presence of endometriosis can lead to scar tissue, especially in more advanced stages. Now, another avenue for scar tissue is surgery itself, so even for mild disease. But this also the risk is increased more with more advanced disease and the more extensive surgery that is performed. And that is because adhesions are a result of tissue damage. So if there's any area of inflammation, raw areas, even blood, infection also, but that's not usually the underlying cause in this case, but just any inflammatory condition, raw areas especially, cause the body to promote healing. Now, the body does its best, but it's not perfect. And so with scar tissue, it's forming tissue that shouldn't be there. And this is more common when there are two raw areas near each other. So the body should really just close up that one raw area, but sometimes when there are two raw areas close to each other, it's going to heal them together because it doesn't realize they're supposed to be separated.
Ah, okay. That makes
And
sense.
unfortunately, in some ways, adhesions are worse than endometriosis because once you have scar tissue, it likes to reform. So the key is adhesion prevention.
Yes, prevention. It always comes back to prevention, doesn't it? Now, you mentioned someone with advanced stages of endometriosis being more at risk. Are there other categories or symptoms or certain type of medical history or anything that would put someone in a category be more likely to develop these issues?
So prior history of surgeries, especially the bigger the incisions, so like C-sections or other laparotomy, so greater than greater than a centimeter incisions, history of infection, especially of like pelvic inflammatory disease, ruptured appendix. Those are the things I think about, or ectopic pregnancy, especially if it ruptured. Anything rupturing is not a good thing.
Yeah. Okay.
Cyst rupturing, if they say a recurrent cyst rupturing, especially if they're endometriomas or some kind of blood-filled cyst, that's also a big red flag for adhesions.
Okay. So you mentioned prevention. Obviously, that's going to be very important in medicine across the board, but I'm interested in hearing what can be done to help prevent scarring or adhesions, both by the surgeon and also if there's anything that patients can do.
Yeah, I mean, everyone wants the supplement, the one thing that's going to prevent
Right.
adhesions, but unfortunately, the number one thing is choosing the right surgeon who understands how to prevent and the importance of prevention.
Yeah.
And so some of the techniques, so number one, understanding adhesions and screening your surgeon for their ability to understand adhesions, why they form, and different techniques to prevent them. Now, this is where NaPro technology really stands out and why me and my colleagues that did the fellowship, why we stand apart with this. And that's because we really had that focus, and Dr. Hilders really has thought about this for 30 years or more.
Yeah.
And so unfortunately now the American Board of OBGYN only recently in the last few years said, hey, this is a problem. They just identified it as a problem, and they said, you need to talk about it with patients and try to prevent it, but they didn't really say how. So that's 30 years behind Dr. Hilders.
Yes.
But understanding, there are doctors that implement adhesion prevention surgery outside of NaPro. And I made a course to help patients really navigate all of this. But in general, delicate tissue handling, keeping the tissue clean, including minimizing blood staying around the tissue, especially at the end of surgery. You want to make sure and irrigate a lot, use a lot of fluid to clear out any residual disease and make sure there's no further bleeding when you are done with the case. Using a laser or very delicate tissue handling and instruments, trying to prevent burning of healthy tissue. So the laser is the nice, cleanest cut. It has less lateral thermal injury or burning past where you cut, which can happen even for a couple days after the procedure, just like any type of burn. It's on a few millimeter range. But with fertility, depending on where one is in the pelvis, that can make a difference. And especially on the ovaries where we don't want to burn eggs, where we can avoid it. In addition, we do other things that are very unique in NaPro, including closing any holes in the skin that lines the abdomen, called the peritoneum. And so we tuck and roll the edges in so that there are no raw areas to close. And we use an anti-adhesion absorbable barrier called Seprafilm. We mix it with fluid and a steroid, and we leave it in the pelvis at the end of the surgery. That helps the organs float apart from each other to try to not just be touching. The steroids reduce inflammation, and the Seprafilm is a specific type of absorbable barrier that will stick to the tissues and help prevent them from getting stuck together. So the more advanced disease, the more aggressive adhesion prevention we need. So we kind of have in our back pocket for the worst cases, like women who are told elsewhere you need a hysterectomy. I said, well, you'll probably need a Gore-Tex. So Gore-Tex membrane is if there's no healthy tissue to sew back together, I put this membrane in. It's like a slippery raincoat. I sew it in those raw areas between the ovaries and the uterus, for example, and I leave that in for 7 to 10 days, and it's removed with another surgery. Unfortunately, it does require another surgery, but that surgery is relatively quick and easy compared to the others. But yeah, so that's pretty much the sequence. So the more extensive the disease, the more extensive we need adhesion prevention. There's some other things like techniques that I use, especially if someone's in the middle between Gore-Tex and our regular stuff. I might do something called ovarian suspension, where I tack the ovaries out with absorbable suture to keep them away from the danger zone, especially if there's a lot of raw areas right by the ovaries. And then those will fall in later once the suture absorbs. That's extremely beneficial. I've seen in some ways, sometimes better than Gore-Tex, and other times I combine Gore-Tex with ovarian suspension. And of note, the uterus and the ovaries, those two organs are the most likely ones to scar.
Okay. See, that information is great because I'm putting myself in the place of listeners here and thinking, oh my goodness, that's a lot of information. How can I use that? What you can do, listeners, is when you go for your consultation with your surgeon, you ask, what preventative measures do you have in place for these issues? What do you do? What's your standard of care? And if their answer is not quite as extensive as what you've just heard, maybe we can ask another question to dig deeper to find out what is actually done. Find out what the different approach is based on the stage of endometriosis they find or the severity, and let them tell you what their approach is going to be depending on it. Obviously, you can't know going in. Maybe you've seen, like she said, endometriomas, and maybe that's there, but most women don't know going in what stage, how severe their endometriosis is going to be. That's okay. You can say, what would you do if it's stage 1? What would you do if it's stage 4? What would you do if there are adhesions everywhere when you go in? And go back and listen to this episode. Compare what she's saying with what your surgeon is recommending. And if you don't feel like they're doing as much as you want them to, then go to another consultation. You can always find another surgeon, but you want to go to someone who you know is trained and experienced. Obviously, someone who is a surgical fellow with NaPro technology received this type of training with Dr. Hildreth. And of course, Dr. Whittaker is the same training that you experienced as well. So women who have endometriosis, they want to have one surgery and have it done with. They never want it to come back again. Outside of maybe having a Gore-Tex surgery to have that removed, are there any things that can be done, again, either by the surgeon or by us as patients, that can potentially help to reduce the chance of having that surgery again?
Yeah, so for my patients, we'll do a diagnostic surgery, treat if it's mild to moderate disease. If it's severe, bring them back for a longer robotic surgery so that we can really talk about a game plan, strategize, and make sure we put enough time, attention to their disease and adhesion prevention. So really focusing on a potential series of 3 in that one, I see that being the best that we can do, really just doing a good job, right? And there are people that, once you have endometriomas, those are the most likely to recur. That happens, unfortunately. But if we do this type of surgery, that repeat surgery down the road is much easier for me as a surgeon. So if I have to reoperate on a patient, I'm always hoping it's my own and not just some random person that, if it's a repeat for advanced disease, I hope it's by a NaPro surgeon, because it's going to make my job a lot easier typically. And, one thing, for example, other surgeons may not even do is reclose the ovary after removing a cyst. Some of them just leave it open. So, that alone, some surgeons just quickly take everything out and get out of town. And yeah, that's really nice. As a surgeon, you want to get in, get the disease out and be done. Yeah. As a surgeon, it fits our personality just to do that. It's hard. Okay, the disease is gone now. Let's fix everything, try to make it as perfect as it was, close everything together. And really, again, with the ovaries, not only do I want to close it, but I want it to tuck and roll the edges in, kind of like the hem of clothing. It rolls in. You don't want to see frayed edges. It's very similar.
Yeah, I can imagine that would make a big difference. And knowing that you have a surgeon that's really going to go the extra step to make sure everything is set up to heal as easily as possible, especially when you think about the context of this surgery. One, we want women's quality of life to improve. So we don't want them to experience pain. We want them to be able to go cycle by cycle by cycle and feel good and go about their lives. But we're also thinking about the second, or maybe it's not second, but one of the most common one of the most common symptoms of endometriosis, which is infertility. So women who want to preserve that fertility so that they can go on to conceive children or conceive more children. And so you're thinking about their best interest and their health down the line, which of course is incredibly important. So
yeah, because adhesions can also cause infertility and pain. Is probably one of the main reasons why women who go through surgery continue to have those types of issues. It is actually adhesions when the disease is cut out properly. Other things it can lead to are more medical complications down the road, especially with very extensive adhesions, and definitely more difficult surgeries down the road. And one other thing I wanted to say, we did not touch upon that patient prevention.
Yeah.
I don't know exactly what we can do for prevention on the patient end. There's some protocols some NaPro surgeons have implemented, like anti-inflammatory type diets, high protein diets. I've tried steroids in some of my oral steroids and some of my really, there's this very small subset of women that have some kind of autoimmune type inflammatory reaction that are just very pro adhesion formers. And that's a very rare population. So I don't like to bring it up too much and focus on this. But for those type of women that just seem like every little thing causes a huge scar, I have tried steroids, talked to them that there's really no data for that. And I do a short burst after surgery. But, low dose doxycycline can also be used for inflammation. So there's some theories out there as to how to try to prevent, but there's nothing out there that's solid that on the patient end you can do other than not overdo it.
Yeah, taking it easy, making sure to rest up and heal. And like we've been talking about, really screen on the front end your surgeons and make sure that they are knowledgeable and skilled. And I know, because I work with hundreds of clients, that insurance is important, proximity is important, and of course these things matter. But when you think about the long-term effects and these possibilities, the weight of this conversation here, it may be worth traveling. It may be worth even having a consultation with someone who may not take your insurance, or maybe at a hospital that you didn't originally plan, just have the consultation and see what kind of a difference there is in their plan and their, care options for you, and use that to help weigh your decision. Yeah.
Absolutely. Get multiple opinions. I think please do that. I did that for my husband's back surgery, and it helped us tremendously. Even if it didn't change our mind with what surgeon we went with, it gave us a lot more confidence.
Yes, absolutely. Well, I know you are a wealth of knowledge. You could probably talk about this all day if we had the capacity for it, but I really appreciate you taking the time out of your schedule to share this information, especially with those who are battling endometriosis, because I believe it, you believe it, they deserve to know. So thank you so much. Listeners, I really mean it when I say you deserve to know this. We want you to be able to confidently advocate for yourself and get the best care possible. Too many women are stuck getting inadequate endometriosis care or no care at all, and we want to do all we can to change that. So maybe you learn your first little bit of information about endometriosis in our Endometriosis 101 download. It's free and on our website. Maybe you join Dr. Whittaker's Restorative Reproductive Medicine Academy. Maybe you talk with us about learning the Creighton model system. We want to make these resources available to you. So make sure to look in the show notes for all of the links there. As always, thanks for listening as we continue to explore together what it means to be woven well.